it? Well, not liked it, but comes easier to some than others. That I think is a fair statement. What I just remembered now that majority of you are here is do that SONA extra credit. I got an email again that y'all are at still 60% range. So do it so you can get, 7 points, 8 points, 9 points. Peer pressure all the people in your groups to make sure that they did it because you can get 10 points extra credit, which is so much better than 6 points extra credit. So make sure you do that. Where did here we go, found it. Alrighty, last one. Schizophrenia and other psychotic disorders. All the good stuff, right? This is probably what you thought the whole class would be on. Or at least that's what I thought when I was an undergrad. Whatever. Okay, so here we have the learning objectives, the main points, blah, blah, blah. All right, so first off, let's just talk about what is psychosis. Psychosis is the loss of contact with reality. And that's actually a very broad statement, I would say, because as we mentioned when talking about memory, lots of people have little phases where they don't know where they are, don't know what's happening around them, and then they jump back right to, right? We gave the example of you're driving home and you don't know how you got home, and all of a sudden you're there, right? But what we want to note is that it's a significant loss of contact, right? It's not just that momentary blip where you're like, ooh, I really wasn't paying attention and I lost contact with reality. This is much more significant than that. And what we also want to note is that it is the hallmark of schizophrenia, that it's that significant loss of contact. And especially with schizophrenia, you're going to be seeing this for a significant amount of time, that loss of contact. But let's talk about the history first. What we think of as schizophrenia as a split personality disorder is a really major misconception. What I want y'all to think of more so is that it's a different connection to reality because of different abnormalities. The first description appeared in 1810. And then the term dementia praecox came about in 1896 to refer to mental deterioration at an early age. And then schizophrenia came about in 1911. There's significant risk that we can see throughout genetic and hereditary connections. As far as the risk is concerned. Lifetime prevalence, though, for the general population of developing schizophrenia is only at about 1%. And the risk is higher for those who had older fathers, for those who had a father at 50 plus. And that means at conception. So not that you're thinking of, well, my dad's 56. No. When you were conceived, I mean older fathers. Or that a parent is in the dry cleaning business. Isn't that so interesting? Kind of crazy, probably connected to the chemicals there. And as far as how that can maybe affect biologically the fetus. The country of origin, we are seeing this within more Western societies. We also note that age of onset is getting younger. Now we are seeing this typically beginning in late adolescence to early adulthood, but still the most average age range for onset is about 18 to 30. Women have a higher risk of developing schizophrenia around the ages of 40 and 60, so late onset. But we do see that overall schizophrenia is more common in men than in women. So don't go home worrying that you're going to have this. Because most likely even y'all are getting out of the range that you would see it. Because here we have age, well, let's look at females first. That peak is hitting at about, what does that look like? 24, right? And for men, also about 24. And look, it just goes down from there. So if you're like 24, don't worry. 2 hands popped up. I saw Samantha and Alyssa. Samantha.
What's it about like the dad being over 50?
That we see also with autism. We see that also with diabetes. It's just the quality of the sperm decreases with age.
But it's like constantly being reproduced. That's what I get.
It is constantly being reproduced, but the quality of it, it's not as good. Like the genetic like makeup of it is not as good. Yeah. Alyssa.
I was just gonna say, how likely is it for like somebody to get schizophrenia if they're like, say their dad had it?
More likely, the risk factor
Like
definitely.
how likely?
Given it.
Like very likely, because my dad doesn't have it, but my dad's dad had schizophrenia,
Uh-huh.
and he like died by the age of like 50.
Uh-huh.
But so my dad don't really talk about it, but I know like sometimes my dad will be like paranoid and like dad stop. Like,
Well, if he's
so-
look at this, you can show him this, right? Like look at how that decreases. How old is your dad?
He's 47.
Blue, 47. Look at that.
Yeah.
Like 0.
He's not like worried about it, but like he has talked about it before. But I'm like, you're way over. Like you're fine.
Yeah,
No.
totally. I mean, just because the risk factor is there doesn't mean it happens. And like your dad's attested it to us. I would show him this and be like, look what my teacher said. Like you're
I
maybe
think
at 1%.
sometimes he like gets in his own head too. Oh my
Yeah.
God, I have it. And I'm like, you're fine.
How old are you?
24.
Look, you're like, if you get through this year, you're gonna be. Look at this steep decline right here. It's amazing. Right? Like, look at that steep decline. It's gonna be fine.
So good.
No, but yeah, because I'm just kidding. Please, I'm just kidding. If your dad doesn't have it, then that's
No, he doesn't.
okay. It's fine. It's like also focus on the like 1% of the
Yeah.
entire population. You know, it's like so rare. So rare. Okay? I don't want to scare you.
No, you're not scared. I'm just curious.
Okay. And again, risk does not mean that there's going to be a cost. Alrighty, but let's look at the hallmark symptoms that you could be picking up at these earlier ages that could then lead into full-on schizophrenia. We've got delusions, hallucinations, disorganized speech, and behavior. Let's look at all of them. So delusions, I think, are less understood because they get clumped in with the hallucinations. But delusions are those beliefs. So it's that like paranoia, it's the like disturbances in their thinking. They often have like very confusing illogical leaps that they make. That there's like something controlling them from above or from within. That there's like just really like contradictions in their speech and thinking. And then also that there's like very external agents of those controls of thought. So it's not a hallucination, which is too far ahead in the slides. It's not a hallucination in that like they're seeing something or hearing something that's not there. It's more that they think that something is controlling their thoughts that isn't themselves. Do you see how that's a difference than like hearing something or seeing something that's not there? Okay, cool. And then that the neutral environmental event has personal relevance. That's a really big one as well. Again, not that they're seeing something or hearing something that's not there, but that the fact that this eraser is standing up straight is telling me, Nina, that I'm going to be standing up straight today. Like, it's like totally illogical, right? Like, I'm gonna knock over your eraser right now. And that could be like, right? And you're like, oh, I'm gonna have a bad day, I'm gonna fall flat on the floor. Like, it's just like totally illogical, has no, like totally illogical, right? Doesn't make sense at all, but it's like completely neutral, has nothing to do with anything. And you make these logical leaps about what it's meaning in the world and your environment. Not to be confused with like step on the crack, you'll break your mother's back kind of stuff. It's that to the extreme, I would say. It's that to the extreme. Make sense about this delusion? Okay. So, just thinking about the delusions and how we can determine if the person really is having delusions, or maybe they just are a little like goofy, right? Like there's some people who are the like step on the crack, bake your mother's back, like, ooh, just missed the crack, what does it make a difference, right? That's a little goofy, and those people don't really think that like if they step on that crack, their mother's back is going to break, right? But with someone who really is delusional, they could really believe that. Like they would be scared and they would be like, oh my gosh, because that happened, that definitely means that. Like they're just much more like solid in their like delusional beliefs than the people who have like a few superstitions. So I think that can be confusing for people sometimes, especially when it's more like relational stuff of like jealousy. Because a lot of people err on the side of a little jealous. Maybe they have, you know, an internal working model that says like they're bad and others are good and that they don't deserve anyone. And then they can tend to be jealous, right? And be like, ooh, I bet they're like sneaking off with someone else. And you could like not be delusional and have that belief, but you could be delusional and have that belief. So that also gets pretty tricky. It's just pretty much to the extreme of like, well, I've been looking through their text messages and there's this one text message that said yes, right? And I know that that can only come from a woman, and that woman is probably really attractive and like they can just go off. But like someone who's a little jealous could see that text message and be like, what's that yes about? Less delusional. So again, it's about, you know, how strongly held are those beliefs. Let's watch this video.
I have a question. How is this differentiated from like OCD?
I was just gonna ask that, yeah.
Because it sounds the same.
Bullshit.
Like,
I don't even know
obsession.
what,
With like this.
Like with
OCD,
the crack, like
like they
not
feel like
stepping on it.
I have to do this or else something.
Oh, okay.
yeah.
So if you were to ask someone with OCD, logically, do you think if you were to put your foot down right now, would your mom's back break? They would say no. They would be like freaking out about it, right? And they would be like, I don't know, you know, I just know this is, I shouldn't do it, and it's really strong, and I just avoid it, right? But if you were to ask them logically, and you were able to calm them down, they would be like, no. Someone who's delusional would be like, yeah, it's gonna happen. So that's the big difference there. It's all about like, you know, that strongly held belief could be considered delusional by non-believers. Like, no one is gonna believe that, right? Like, that's a good line of like, no one believes that if I step on this crack here in the carpet, then my mom's back just broke. Only the person who's delusional would believe that. Yeah.
So in an extreme situation here, what if they believe that actually step on a break, something seriously happened to their mom or their back did break? How would that like literally drive really more?
Oh my god, they would literally have
That would probably not help the situation. Probably would not help the situation. Sometimes those freak accidents do happen. Like this was so sad. This little kid had recently learned about a snake at school. That was like a really scary snake. Like, I don't know, they were talking about boa constrictors as they do in kids' school. And that night, there was a garden snake in that little girl's room, okay? And she freaked the out, okay? Rightfully so, right? Rightfully so. But if that clinician did not know that she had just learned about boa constrictors that day, that girl would be seen as completely delusional for how much she was freaking out about this garden snake, right? So that's the kind of information that you like have to keep in mind. It's like, is this a normal fear or a normal reaction? Or like when we're able to calm them down and teach them the difference between like a garden snake and a boa constrictor, like, are they able to understand that? Then you kind of can make a better judgment call. Cyrus?
Saying like this factor into
Yes. Right, exactly. Like if that actually really happens to them, like, I mean, maybe pathologize it a little because they shouldn't have had that thought in the first place, really, if they really believe that, whatever. But then, like, if something like that really happened to them, like one time, talk them through that. And then if they're being able to talk through, probably not delusional. But if they're not able to, then they might be. Might. Okay, let's watch the video. Bless you.
Thank you.
What are some of the symptoms of paranoid schizophrenia that you are suffering from?
Occasionally I hear voices.
Uh, What kind of voices are they? Can you tell me about the voices?
I have all kinds of companions, some fixed,
Some fixed and.
some, I have all kinds of voices,
Hmm.
some fixed and some.
Can you tell me a little bit about it?
Well, I talk occasionally, at that time, occasionally talk to myself. Think, actually, when I was very deprived, I was absolutely in love with baseball. I used to draw up charts, fictionalized baseball players. That's how much I was in love with baseball. And these are not real players, these are names that I invented. And I would give each player an individual name. That in fact was a very early symptom of my disease. That was when I was very young at summer camp at Kirkland. Where it first began to manifest itself.
How old were you?
Well, I had my first initial difficulties in seventh grade when I was enrolled at Belmont Hill School.
What were some of the beginning difficulties?
I said before I had friends, some fictional, some non-fictional.
Were these friends friends that you could see or friends that you could only hear?
Well, I didn't see them so much as I could hear them.
Could other people hear them?
Could other people hear them? I don't.
When you started hearing voices, was that something that upset you or was scary to you?
Actually, when I noticed for many years, I was able to function in the academic community for many years. When I was in my senior year of high school, it manifested itself in a large way. Well, at first, I spent a few weeks at Westwood Lodge, and I was diagnosed at that time as being tired, possibly suffering a nervous breakdown from all the work I had done previous year in high school. And they hospitalized me in Westwood Lodge and they put an initial diagnosis of nervous breakdown. But then when I moved on to tests, it blossomed into a real problem. However, I was able to complete my senior year in high school. And I did spend 2 years at college, 2 very rough years at college.
That time that you were in the hospital the first time, your senior year, did you tell anyone about the voices?
They at that time, like I said, they made some original diagnosis with me.
When the voices talk to you, you said that you have fictional and non-fictional voices that talk to you?
I had friends.
Oh.
Okay, I had friends.
Okay. Can you describe the difference between the two groups, the fictional friends versus the non-fictional friends?
I love history. I love talking about history, particularly. In fact, although I was enrolled as a political science major, I had difficulties. Like I said before, I had friends, some from history and some from names I had invented, people I had invented.
What did y'all notice?
He seems very highly medicated.
Yeah, wow, really slow in his speech, right? Really slow in his speech. He for sure is on antipsychotic medication. You can tell by, his eyes just being like kind of unfocused and his speech. Good pickup. Amanda?
I feel like he didn't really answer questions like in depth, or I don't know, like I didn't really understand what he was talking about like, the whole time.
Yep. That like lack of clarity and, not really going chronologically in what he was saying. Did y'all pick up any of the delusions that he mentioned?
The historical friends or fiction.
Well, that I think was more getting into hallucinations because he said he saw them and heard them, or at least that's the way I understood it. Did y'all understand it that way, that he saw them and heard them? The delusions I thought were more the like baseball players. Like when he was talking about like the lineup that he was making and that they were like all his like baseball playing friends or whatever. It was really confusing. But I thought that maybe was more about the delusions. And then also like who knows what he was saying as far as like, you're right, the friends versus the not friends, like if those people that he was talking about were real or not real. Yeah, Kevin?
I was gonna ask about the baseball players. He said that's playing around, they said, when he was younger.
Yeah.
How was that considered a delusion? Because like, from my knowledge growing up, you make things like that, if you put our own people in it, just.
Yeah, so there's a difference between play, right, and being delusional as a young child with potentially early onset schizophrenia. And again, you do have to make that like line, because you don't want to pathologize normal imaginative play. But if you ask that kid, right, like, are those real? Like, do they exist like Alex Rodriguez exists? They would be able to say no. That makes sense?
It brings more questions.
It brings more questions. What's the next question? I'll give you one.
Being younger, people make believe friends all
Yeah.
the time, so is that would they categorize that as a delusion?
Definitely not, because again, it's normal development for a child. But what becomes abnormal is when it either goes on too long, right? Like well past the age of, 8 honestly is a bit old for an imaginary friend, I will say that. And then also, when you're talking to most, like don't do this because it's kind of mean and that they know it's not real. But if you were to talk to them and be like, oh, do you see them? And they'd be like, no, I don't actually, like if you really like got to it, they would be able to identify that imaginary friend was not real. That they made it up, and it's usually like a security blanket for kids who have imaginary friends or like kids who are lonely, which is why like don't do this to a kid. But they know it's not real. Yeah, Cyrus.
He even had the same reaction when was posed with that question. She was like, are they real? And he kind of like hesitated away and they kind of like went in a different direction.
Mhm.
Sometimes the person
So those types of like things are in the abnormal direction.
you could tell that he knew what.
Right, because probably people had told him those are not real. Yeah,
He
Amanda?
also said he was in 7th grade though, so that's like
Way old for
really
that.
old, yeah, to be making up friends or having imaginary friends.
Yeah. You can have early onset schizophrenia as a child, you can. And then again, you do have to be cautious, but usually you're seeing those hallucinations as well, especially for like early onset, like the earlier onset, usually the more extreme and the more severe the case of schizophrenia. So you're probably seeing those hallucinations as well. Yeah, Peyton?
I'm confused, so how, you could see the non-fictional ones and the fictional ones?
I was confused about what he was saying too. It's possible that was either or both, and that could be the possibility for hallucinations. That they can be, something that they see, like they really do see it, or it can be something that they just hear and they don't hear it. I think he was actually saying like he heard some. Did you understand it, Sarah?
I think he got really defensive when she said something and he's like, friends, like
Right.
corrected her right away, like, no, like they're almost like saying that they are real. And I think that he just said that they weren't because everyone had been telling him like, you're crazy, they're not real, so he feels the need to defend himself.
That might be the case. Yeah, but with hallucinations, and I didn't really understand if he did see them or didn't see them. He definitely heard them. That I think was pretty clear from what he was saying. He definitely heard them, whether they were fictional, non-fictional, who knows what that even meant. Definitely heard them. So that's an auditory hallucination, but you can also have this visual hallucinations. And that I thought was unclear if he was saying he did see them or didn't see them. I couldn't really tell from that video because again, and also like when you are interviewing someone who does have schizophrenia, a lot of times they have a lack of clarity in the way that they're speaking. Ooh, I did that. Let's see if I can make it come back. Yes. So that it is sometimes hard to follow and understand what they're saying.
Plus, they're all medicated.
And also when someone's on antipsychotic medication, that happens too. Yeah. Let me get that. Okay. Yeah, so let me talk about hallucinations because I have a feeling that will probably answer some of your questions. So it is a sensory experience that individuals note that it feels very, very real to them. That just like I am seeing Michelle right in front of me, they could also be seeing someone sitting in this chair, you know, that has like brown hair and dark skin and looks really friendly and is smiling at them. And they seem just as real as Michelle is real. And that would be, you know, a visual hallucination, which is less seen than auditory hallucinations, but are still seen. And then if the person started talking, it would be a combined auditory and visual hallucination. Obviously, there's no one here, and there are no voices other than my own. But auditory hallucinations, you do hear of more often. They do occur within individuals more often. They are often the start of the hallucinations for people who suffer from schizophrenia, and they're quite common. And also, what we need to separate out is that hallucinations can happen with individuals who are depressed. You can have depressive symptoms, depression, whatever depressive one it is, pervasive, whatever, PDD, MDD, and you can have like some psychotic features. Did y'all see that when you were looking at the book maybe? It's just an addition with some psychotic features. Most often that with some psychotic features is an auditory hallucination. That they hear things that aren't really there. A lot of times also people can recognize that it's not actually real, that other people can't hear those things, and it's just them, but it feels very, very real to them. And then sometimes people, like some in the video, some people noted like he became really defensive and probably did think those things were real, but he definitely still heard it as like an external stimulus. So this is a really fun story that I heard of. That a person thought that they were having auditory hallucinations, but it was really just like their own internal voice of them thinking. So like what's really key is that it has to be external, okay? That like it's not how you all can be thinking to yourself of like, aha, that was funny, or oh, she made another not funny joke. Whatever your internal thought was, it's internal. The key to this is that it's external. Also different than like your mind's eye, right? Like you can visualize someone sitting in that chair next to Michelle, but then you can open your eyes and see no one's actually sitting there. Again, it's different because you see it as external to you. That's really the key. You can also do a PET scan or an fMRI. And those studies do suggest that auditory hallucinations may actually be misperceived as subvocal speech. Isn't that cool? So like you could actually be hearing it and then it's not actually an auditory hallucination. It's just like you're hearing like things that other people really can't. Isn't that cool? So sometimes happens if you just have like amazing hearing. Okay, so you do want to be careful about that, I guess. Okay, let's watch the video because this is pretty hard to describe. So you just have to hear it and see it, I guess.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there's either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime, when I go outside in the sun, I used to show my friends things they hadn't seen before, like the halo. See, like the halo, when I was 19, when I was preaching, I had my trial time, I used to see the light on my shadow on the ground in the daytime. And now, from ever since then, it's like the light coming further down over my body, around my shadow, and over my body, around my shadow, and I see the light, which is your halo, your aura. And that's why everybody can't see that. Well, if you see, you got some of the drugs too, we say, and I don't know what's for real. I know what I see, but I don't know if for real or not. And so that's why you see people different. It's like that anointing. I see, like, sometimes when I come outside, I can see when I look at the trees, the wind start blowing. But we know we got oxygen from the plants, and we get them carbon dioxide. And so it's the wind usually blows sometimes, but it don't blow all the time. Like when I'm in the house a long time, it blow real strong.
Oh boy. So, chances are none of y'all follow that. And that's why it's kind of confusing to even explain, because it's so confusing when you hear it. Obviously he was saying something about like halos or auras. That's all I was able to pick up.
Wind.
What?
Wind and trees.
Oh, you heard wind and trees?
Yeah.
Oh, okay. You picked up more than I did. It's really, it's impossible to follow. That's the bottom line. It's impossible to follow because it is so illogical. It doesn't make sense. So you can't follow it. It's not like, oh, I'm not following it and I don't have enough intelligence to follow this person. It's what they're saying is totally, I don't know, just random words sometimes. So what you can see in what you just heard is that there was probably all of these they, may conform to semantic and syntactic rules of speech, right? As in like they were, saying words, right? Like at least the words that we were able to pick up, but they didn't make sense together. So there's disturbance in the form, not the content of the thought. So that could be the case, or a cognitive slippage, as in like words are just coming out of their mouth. Or I think you also have these, you could just have totally made up words, or they could have just a formal thought disorder, as in like the words that they're saying really just don't make sense at all. It could be all of the above. I would say it's probably all of the above is what that sounded like. Yes, Tristan.
Could it also mix with the fact that he mumbled a lot and talked really fast, so
Mhm.
it makes it a lot more difficult?
Yeah. So that would be probably in the form.
Okay.
The disturbance in the form. And like maybe there wasn't a content problem there, but there was probably form problems. Yeah. Content would be the failure to make sense. And then also, he probably also had some made up words in there too, maybe when he was mumbling. I don't know. So yeah, all of them.
Was that with medication or without? And how he talked? He was on medication.
That did Batman that we just saw, he said he was on medication? Oh, okay, so that's actually really big thing that y'all should know about this, is that if people are having delusions, hallucinations, these disturbances in speech while they're on drugs, like illicit drugs, like heroin, cocaine, whatever it is they're taking, then they do not meet criteria for schizophrenia. That guy, I don't know what he was talking about, so I couldn't say.
Because they were like recording him and they said he had.
I thought he was something like ever since they.
Yeah, he was
Yeah.
like, it's because they drugs, I see things.
Okay, so that was probably a cognitive distortion. Because the drugs are, I mean, sometimes the drugs don't work. We shouldn't say drugs, because when you said drugs, I heard cocaine, whatever,
Yeah.
which can cause these things. medications. Let's use medications. So medications are hopefully helping with the hallucinations, hopefully helping with the delusions. That's what they're supposed to do. They don't always work. I mean, sometimes they work, sometimes they don't. Sometimes you have a really high dosage and it can be helpful, and sometimes you have a really high dosage and you can just totally numb a person out completely and they just have no words to say anymore at all. So that's kind of on the medical professional team. But what I do want you to know is if it's drugs, okay, like if what is causing all of these symptoms that we're talking about right now that together make up schizophrenia, if that came out of cocaine, whatever their drug of choice was, they do not meet criteria for schizophrenia. That's what I wanted you to know for that. Medications that we're giving people sometimes can actually cause hallucinations. But again, they would not meet criteria for schizophrenia if it was someone who was not meeting criteria before, right? Like it could have just been someone who had a bad reaction to a medication, whatever it was, and then hallucinated. Like that happens. And then you should see the hallucinations go away when the doctor takes that person off that medication. Again, telling you they do not meet criteria for schizophrenia.
Sorry, I guess my
Yeah.
question, to be more clear, was
Mhm.
does that speech, like the way he talks, is like a symptom from the schizophrenia itself or from medications?
So the black man that we just heard, that's schizophrenia. The white man who spoke first, that I would say it could be schizophrenia, but likely is also medications. Got to differentiate between the two gentlemen. Okay. Now we good? Yeah, Sebastian.
No, I just think
Aw, thanks, man. Okay. Now we've also got disorganized behavior in addition to that disorganized speech. So this can occur in areas of daily functioning, and we do need to see this in multiple areas of daily functioning. So this can be at work, in social relationships, within self-care, at school, doing whatever activities that they do, grocery shopping, many different areas. You do need to see this. Because if you're only seeing disorganized behavior in one area, that should be a red flag about what is happening in that one area, not that they truly have disorganized behavior. Also, when we start talking about what are those disorganized behaviors, you will see if it truly meets criteria for disorganized behavior. Obviously, you're going to be seeing it everywhere. So we have catatonia. Oh, bless you. Catatonia, which involves almost no movement at all. Sometimes in an unusual posture. So you could see someone who is suffering from catatonia and they could just be stuck like this. Like just stuck. Like they could not, yeah, I know, like this looks real uncomfortable to be holding your arm like this for a long time. But that is what it is, that they are just stuck. Like they could not move their arm if they wanted to, and likely they don't know that their arm is even up there in an awkward position. So there's that. Then there's also just like erratic behavior in general, which would be, running in an awkward way, like just all of a sudden. Or, all of a sudden being like aggressive to themselves. Like they could just all of a sudden like just whack themselves. I don't like saying aggressive to others, but that can happen because usually people with schizophrenia are actually aggressive to themselves. But they could also be, if they're paranoid schizophrenic, they could be, just like all of a sudden like hiding or ducking or like just doing like just really erratic behaviors that don't necessarily match anything that's going on in their world. So that is what that is. Then we also have a definition between both positive and negative symptoms. So similar when we talk about like behaviorism, when you think of positive, what do you think of? An addition. I want you to think of addition, something is being added to the environment. Or negative, something is being taken away from the environment. Taken away from the environment. So people can have both positive and negative symptoms when they have schizophrenia. So for positive symptoms, what can you think of that would be added that we've already talked about today? The voices, they're seeing things, all of those, they're being added. So it's, something in addition to what normal people are experiencing. Then there's those negative symptoms. So it's that deficit of normally present behaviors or abilities. So it would be like that flat speech, or like that confusing speech that we just heard. So it's like a lack of ability to speak in a cohesive way. You could also have like very flat or blunted emotional expressiveness, that it would be just like being very like blank, I guess, is a way of understanding it. So you can have deficits and you can have more positive symptoms. What do you think has more poor clinical outcomes? What's worse? Positive. The more hallucinations, the more auditory delusions that you're having about the world around you, it's actually worse. That's at least what we see. Both are bad. Both are really not good. Both have pretty poor outcomes, but it is just worse off for individuals when they have more positive symptoms. Because negative symptoms you can kind of train people into getting some of those abilities back with a lot of therapy, but the positive symptoms are just really hard to get rid of. Okay, so here we have just a list of some of those more positive symptoms. So the delusions, the hallucinations, the big behaviors also could also be, like I said, someone could just start like running all of a sudden or like hitting themselves. That's also a positive symptom. Or also the like disorganized thinking. In that like they have like additional thoughts, or that they are like scrambling their words, things like that. That also could be seen as a positive symptom. Went too far. Makes sense? So it's like that excess. That's a good way of saying it, like excess and distortions. Okay, so as I kind of already mentioned, maybe I shouldn't have gotten ahead of myself, there's what's called paranoid schizophrenia, and that is when you meet criteria for that, you have that additional paranoia as far as what's going on in the world around them, that they're illogical, absurd beliefs that makes them very, very worried and very hyperactivated about what could happen in the future or what's happening to them currently. So that helps them, that allows someone to meet paranoid schizophrenia, that they have, thoughts about the government watching them, or thoughts about maybe aliens coming to get them, or, it's just paranoia, worry, fear. It's like that excess fear, and that, obviously is illogical, obviously also is very delusional, can also have those hallucinations, whether they're auditory or visual, but it's that, absurd beliefs that are paranoid in nature, that are worrying and they're fearful in nature. Then there's disorganized schizophrenia, which I think is less known. I think most people think of paranoid schizophrenia, but disorganized schizophrenia is actually quite common. Again, that is that disorganized speech and behavior. It's either like pretty flat or inappropriate affect. It doesn't have that like hypervigilance that you would see with paranoid schizophrenia, but it's more that disorganization of the speech, like what you were hearing from really most gentlemen talking. They probably met criteria for disorganized schizophrenia. And then we have catatonic schizophrenia, and that's where you could just see people like frozen, where it's the pronounced motor signs that reflect great excitement or stupor. So it's like, they have like a big whack and then they're frozen. Or, they don't even do that. Like they don't even have their big whacks, like the big great excitement or like hit to themselves, but they may just be like super slow, like in their movements and their gestures. And sometimes, again, they could just get frozen and stop and just like be blank for long periods of time. Any questions on those? That all those make sense? Okay. But there's also other psychotic disorders, like schizoaffective disorders, schizophreniform disorder, delusional disorder, and brief psychotic disorder. And also, not here with what did I just say? With psychotic features, sorry. So other options where you could see features of schizophrenia but not meet full criteria for schizophrenia. You have schizoaffective disorder, which has those features but not as fully, and then has a very severe mood disorder. So their mood, as opposed to being schizophrenic, you would have that like flat affect and that like flat mood and like just that blankness in their face. With schizoaffective disorder, you would have a severe mood disorder. Like you would maybe have like those ups and downs that you would see in bipolar 1. Then there's schizophreniform, which is schizophrenia-like as well, but it doesn't last as long because the psychosis can only last a month, at least a month, but less than 6 months. So that's just a timing thing. And then there's brief psychotic disorder, which is just a sudden onset, and then it's quite brief, so less than a month. In that it's disorganized speech or catatonic behavior. Again, some of those symptoms that we would see in full-blown schizophrenia that comes on really fast, as opposed to schizophrenia, which is more of that like slow build of more and more symptoms. And that brief psychotic disorder like hits at once and then just goes away. And then we have delusional disorder, where you just have the delusions. So you wouldn't have the hallucinations, you wouldn't have, the different behavior, you wouldn't have that speech stuff, it would just be the delusions. And in a subtype of delusional disorder, which is called erotomania, the theme of the delusion involves great love for a person, usually of higher status. So it even can be something that like is pretty small, likely the person, doesn't have too much difficulty going about their lives when they just have like maybe one disorder, like one delusion, as far as like this crazy love for a person that they don't know, like a famous person or whoever it is, a baseball player, hockey player, I don't know. So they could probably go on and have a relatively normal life and be rather successful with these delusions. But as the delusions grow, as they have maybe more of them, or they're more pervasive, they're going to have more and more difficulty. But definitely more treatable, this delusional disorder, than any of the schizoaffective or schizophreniform or schizophrenia disorders. Okay, so now let's talk about those genetic and behavioral factors that I hope will not concern you, because just because there's correlation does not mean that it's definite or false. So, true or false? Genetic factors are clearly implicated in schizophrenia. Mohammed, do you want to try?
False.
It's not false, it's true. So they are clear, but thank you for participating. They are clearly implicated. We do see that a lot of times this is passed down between parent to child. Like I mentioned before, it's mostly within men, but not necessarily. Definitely not necessarily. But what we do know is that, again, just because there is a higher risk factor does not mean that there's going to be necessarily schizophrenia in offspring. So the following slide shows that having a relative with disorder significantly raises a person's risk of developing schizophrenia. Let's look. So here we have this slide here. And what we have is a lifetime age-adjusted average risk for the development of schizophrenia-related psychoses in classes of relatives differing in their degree of genetic relatedness. So identical twins, 100%. That's pretty crazy. They are, gonna have so much of that shared gene, and they're at about 50% risk of developing schizophrenia. But look at that huge, jump even to fraternal twins, right? Parents were down to 10%, right? Is that what that is? Or I can't see. Less than 10%, sorry. Risk of developing schizophrenia. Grandchildren, is that 5%, right? Uncles and aunts, it's like 2%. First cousins, 3-ish, 2-ish, right? 1% we know is the general population. So even this, you can also show this to your dad. This would probably be really great to show, like even with this risk factor, the risk of developing schizophrenia when a parent has it is 7, it looks like ish. So pretty good. Yes.
Have they been able to determine what genes that?
They have identified some genes. They have. On this next slide, we talk more about that. In that they have identified some genes. Do I have it written down? They haven't linked it exactly to one because there's likely multiple genes implicated, but they have isolated a few. Yeah. So good questions. What we also see as far as the influence of genetics is concerned, when looking at twin studies and adoption studies, we do find that schizophrenia is more commonly found within that biological connection than within a behavioral connection that you would see within adopted studies. Because within the twin studies, when they are, separated at birth, one twin goes to one family, one twin goes to the other family, we are still seeing whether it's identical or fraternal, obviously depends, but it's more connected to that genetic basis than that behavioral basis within the family. There was a significant period of time that schizophrenia was blamed on bad parenting by mothers, and that has been totally debunked. It's very genetically based, and even so, like the studies of the molecular genetics, like we have been able to isolate like a group of genes, not just one. Likely there's multiple that are implicated for schizophrenia, but even with that, you have to still have in mind the diaphysis stress model, that someone can even have that genetic makeup and not have schizophrenia. So it is just important to note that it's not, 100% something that's going to happen. So again, it's just like the susceptibility to illness also needs to be kept in mind. So again, it's a genome-wide association that we have to keep in mind. To provide further evidence, there's like a large number of alleles that are involved in creating genetic susceptibility to schizophrenia, and many of those genes are implicated all at once, and that's just important to note. What else did I want to note from this one? Whenever we get into genes, I always get a little messed up. Research is also exploring endophenotypes, which are discrete, stable, and measurable traits that are thought to be under genetic control. So those are endophenotypes, which are discrete, stable, and measurable traits that are thought to be under genetic control, which all can be implicated to people potentially developing schizophrenia. Here again, just looking at, the genetic makeup, it's, multifactorial is kind of just basically what we know. There are rare genes that have a large effect that they have been able to isolate. But there's also more common genes that are found in more people that do not necessarily have schizophrenia, that have a smaller effect on the eventual diagnosis of developing it. And then more than half, we have no idea what goes on as far as the genetic makeup is concerned of developing schizophrenia. So basically we know very little, or at least we know this much, whatever this is. It doesn't exactly say what piece of this pie is, but they're very rare. So we know little about that. You definitely can't take a blood test and know. Like I mentioned, there was a large amount of time that developing schizophrenia was blamed on the mother or bad parenting. or on early childhood trauma. That is not what we see as the reason for someone developing schizophrenia at this time. But there are different prenatal exposures that can biologically affect the fetus that could be affecting schizophrenia in the long term. So that could be like a viral infection, birth complications, nutritional deficiencies, and rhesus incompatibility, which is like just biological features of the mother and the child being incompatible, and that sometimes the mother's body will actually like eat the baby. Not eat the baby, that's that way of saying it, but like attack the baby. Some parts of the baby will be attacked by the mother's body. Yes.
I have a question about the genetics thing.
Mhm.
So, like, I knew someone who had possibly a personality disorder, and their brother is schizophrenic. Do those have any association genetically?
Yes, which were the specific ones? If I remember back to the personality lecture, does anyone remember there are specific personality disorders that are connected to schizophrenia? Did anyone write that down? I'm not remembering off the top of my head. And I would imagine probably schizophrenia.
Paranoid?
Maybe paranoid. I don't remember what it is exactly right now. Does anyone remember what they are? I think maybe narcissistic's coming to my mind also. I don't know if that's true. I can look that up, but I did mention it in the lecture. I'm just not remembering now. But there are specific personality disorders that are correlated with schizophrenia within families. So yeah, that's definitely true. I just don't remember exactly what it was. It's not all of them. Yeah, so that kind of also brings in the maybe pregnancy and birth complications, or maybe the viral infection of families who have dry cleaners or work at dry cleaners. But again, you always have to be thinking of that diaphysis stress model, because it is multiple genetic factors with those environmental factors. That's someone who lives in a perfect bubble with no stresses, doesn't have any of the environmental factors that could be isolated to affect schizophrenia. The person is probably not going to develop schizophrenia. But really that current thinking really emphasizes the interplay. So that diaphysis stress model is key for this as well. It's that synthesis. Okay, can you fill in the blanks? Schizophrenia is genetically but not genetically Anyone want to try? I'll give you the first one. Schizophrenia is genetically influenced, but not genetically determined, right? Because it's an influence, but it's not 100%, right? Like it's not determined. There's no like direct causation. There's no definitive answer. There's some links. So now let's look at that neurodevelopmental perspective at schizophrenia. There's definitely biological considerations that we have to keep in mind, because there can be brain abnormalities that we can isolate and actually find for individuals who have lesions on their brain that lie dormant, that are not identified and not potentially removed, which is possible to remove some lesions on the brain. And definitely want to keep that in mind. Like if someone has, any type of lesion or any type of benign tumor that could be pressing on different parts of the brain, you could be seeing some of these symptoms. And if they were able to be treated, you would see an alleviation of the symptoms. So that's really important to note. And hopefully you can also involve a medical professional if some of these symptoms are being seen within one of your patients or individuals that you know. What we also see is that changes expose the problems that result from this brain abnormality. So different, again, it's that environmental leap, that maybe someone moves, maybe someone gets a new job, like big life shifts where their typical pattern and their typical, routine is being shifted. A lot of times that can be triggering for someone, and that can bring up some of that abnormal symptomatology. It can also create a stress on the brain, which could then just exacerbate the difficulties that someone was having. And then also developmental precursors may include some of those like motoric abnormalities, which are also like highly correlated to brain differences or brain abnormalities. What we also see is like low positive facial emotion, and again, it's like that flat affect, and then that high negative facial emotion is also a problem, potentially, that like they could look angry just all the time, which again, we see often for people who potentially have brain lesions or tumors or different abnormalities within their brain, and that, check on that early potentially so that you can potentially help that person, and then it doesn't have to blow into something much larger. Okay, true or false? Brain abnormalities are found in all patients. False, yeah, definitely. Most brains are abnormal. Okay, so looking at more of those brain abnormalities, in general, people with schizophrenia struggle to attend well on treatment. So there's definitely some neurocognitive deficits that we see across it, all different types of schizophrenia. Just in general, it's just really hard for them to focus. I think maybe you saw that in both of those videos where the gentlemen were like kind of spacing out. Again, it likely does look like that as well when you're taking psychotropic medication, but then you could also have that without the medication, and that's what it could look like. So they're gonna have attentional and working memory deficits as well as eye tracking dysfunction. So they're not gonna be very cognizant of what's happening in the world around them. It's gonna be very hard for them to attend, remember different things in a coherent way. Because just thinking about it to yourself, is it easier to remember a sentence that makes sense, or is it harder to remember? It is easier to remember, I said that weird. It's easier to remember a sentence that makes sense, right? Like, I saw the cat fly is easier to remember than the cat I saw flew. Like, that's just a harder sentence to remember. So when you have all those cognitive distortions, it makes sense that they have a lot of attentional and working memory deficits. And then also the eye tracking, which you kind of saw in that first video. Okay. Again, like we mentioned, there's with these brain abnormalities and differences, you could see this within people who do not have schizophrenia and just have some brain abnormalities and differences. You could have that impaired social cognition, where they're, difficulty making speech that's cohesive, that's coherent to other individuals, making connections that make sense, that are lasting. They're gonna have a lot of difficulty recognizing emotion and connecting in that way. Then there can be also a loss of brain volume, which would also be an abnormality that like some people, for whatever reason, just have parts of their brain that are less fully formed. And that could be part of the case. And then also there could be a reduced volume of white matter within the brain, which can also lead to different types of impairments. What also there is as far as those brain abnormalities, there can be just disruptions in brain functioning in different parts of the brain. It can be within that temporal or frontal lobe, which is all up here, which then is going to lead to like difficulty making decisions and having trouble with different tasks and anything that's, needs you to be organized in your functioning, whether that's like just walking to the other side of the room and navigating different like chairs that are in your way, or something much more complicated like making a decision or something like that. There's also what's known as compromised cytoarchitecture, which just means like the architecture of the brain, like there's like lots of different bumps and there's different pathways and there's different, formations of the brain. And that can be compromised and just slightly abnormal and different. And that can lead to, just difficulty handling normal stress levels. We also have, head injuries, obviously, can be, developmentally stunting for different people, can create lots and lots of different problems. As far as, the disruption of the brain development itself, or just disruption within that area that there is trauma to the brain. There's also, differences in neurochemistry, right? Like there's, just different chemicals in the brain, and we've talked about this as far as, just the need for medication. So there could be, dopamine imbalances, right? That's really gonna affect mood. And then glutamate, which is just a fancy word for sugar, and that can also be imbalances, and that can cause different abnormalities in mood and stress and anxiety, whatever it is. Okay, do PAD families cause schizophrenia? No, right? False. That was 1960s, 1970s, if you've ever seen that movie Running with Scissors. Okay, it's a good movie. Okay, bottom line is no. But what we see, is that idea of the schizophrenic mother, the double bind hypothesis, all that stuff has been totally debunked. Not true. But what we do see is that families who are under stress, right, are more likely to have many different disorders, right? Just stressful environments, what we've said as far as the diathesis stress model, right? Stress is just going to make you more likely or have a higher risk to develop any numerous number of developmental disorders or mental illnesses. We do also see that for people who already have developed schizophrenia, it's a huge stress on the family as far as the care that needs to be given to that individual, as far as, just the money and the time that's concerned, the safety concerns for that individual, the care that is needed is a lot. It is a big stressor to the family. We also see that for patients with schizophrenia, they're more likely to relapse if their families are high in expressed emotion. So if they are a family that maybe is a little more aggressive or maybe more emotionally less regulated, we do see that for individuals who already have schizophrenia, it's not helpful. They're better off in a calmer environment, a more regimented environment that's not so affecting. Okay, so a large body of evidence has indicated that lower socioeconomic statuses and end up having higher prevalence rates of schizophrenia. Immigrants also have higher rates of schizophrenia than individuals who are native to their country of origin. And then also people with schizophrenia are twice as likely than general population to smoke marijuana. So that's important to know, so that families more likely to relapse, like I mentioned, urban living, more likely, immigration, more likely, cannabis use and abuse, more likely. Not that any of these things cause it, but they're correlated. Again, this is just another way of looking at the diathesis stress model, really, as far as the genetic factors that are concerned, the vulnerability that may take place within that person, maybe those prenatal differences that might have happened, whether it's stress or lack of healthy nutrition to the baby or a virus, whatever it is, creates that brain vulnerability. Stress is key. Developmental maturation processes are key over time, right? Leads to that psychosis. So diathesis stress model again. Treatments, unfortunately, are not very effective. Before the 1950s, the prognosis was even more bleak, but we have made some pretty good, movements in the right direction as far as treatment and helping individuals with this disorder. Antipsychotic drugs have made a huge impact as far as that dramatic improvement in prognosis. A lot of times, if you get the right medication, people can experience a much more healthy way of living. Currently, about 38% of people diagnosed with schizophrenia function well, 15 to 25 years later. So 38%, it's not so hot, but there's something there that after 15 years of treatment, you're getting somewhere for about 38% of them. It's a little bleak in my view, but it's something. And long-term institutionalization is necessary for about 12%. So about 12%, they will, never get better and will always have to be in an institution. So that also is pretty high, actually, for long-term institutionalization. That's quite high. So that's just what it is, unfortunately. Again, we do have those pharmacological treatments that are very helpful to individuals. if they get, the right amount and the right dosage and the right medication, of course. But we do see them as antipsychotics. What they do is they block dopamine receptors, and in some reason that helps with those different psychotic symptoms. Patients taking second generation antipsychotics, like the more new ones, have fewer abnormal side effects and tend to be better overall. So we have definitely made improvements as far as antipsychotic medications are concerned. But the side effects can be very troubling, like we just saw, like extreme lethargy, extreme flat affect. Sometimes they can even cause more hallucinations, like you can just really get it wrong. It can also cause extreme depression, can cause people to become suicidal, can really just go in the opposite direction of the way you want them to. So you do have to be so careful with antipsychotic medications. But there are psychosocial approaches that do work, I think for that 38%. So family therapy, again, because there's such a stress on the family. And when someone is diagnosed with schizophrenia in the family, you really need to help them be as calm and as organized and as regimented and as, what's the word? Like just always have a very similar routine day to day. So families often need help with that. Case management is just, getting a social worker out there, helping with daily needs and daily issues with living. Social skills training, again, like I mentioned, just helping them get out into the environment, talk maybe in a little more normal tone and ordering so they can maybe hold some type of job. Cognitive remediation for individuals who really don't have it as severely. I think a lot of times it's helpful for individuals who are paranoid schizophrenic in talking about those paranoid ideations and talking about those thoughts, about the illogical, irrational sense of those thoughts, and that can be helpful. Cognitive behavioral therapy, again, as far as, again, what are the cognitions that the individual is having? How can we help them maybe understand those thoughts, that how they are irrational, and how that can lead them to do behaviors that aren't helpful to them, and helping them see that sometimes their behaviors and their thoughts are very mismatched, and that can be quite helpful. And then individual treatment as far as maybe just supportive therapy, talk therapy can also be good. Any questions? Because we made it through. No? Alrighty. So, again, the unresolved issues, why are recovery rates in schizophrenia not improving? I don't really know the answer to that. If we had it, maybe we would know. Does staying on antipsychotic medications provide long-term benefits? Probably not. There's, it doesn't really take away the symptoms forever. It just helps them when they're taking the medication. And then can we attribute the poor clinical outcomes of the medicated patients to the continued use of antipsychotics? We don't know that either. So, yeah, that was it. That was a pleasure teaching you all this semester. Let me know if your groups need any help or if you have any updates on icky group members. Like I said, I will be following up with all groups. So, let me know. And have a good one and good luck with the test.
Oh, do you have to use it? I knew that you only had to have 10.
I got 11 up last night.
Okay.
Or yesterday afternoon, really. And then 12 and 13 we just finished today. So I'll be getting those up as soon as I can.